Welcome to the MS-Perspektive podcast, Perspective with a K as I'm German. I'm Nele von Horsten, MS patient, patient advocate and author. I'm bringing you interviews, inspiration and information about living with multiple sclerosis and show you ways how you can positively influence the disease and make the best out of your diagnosis. On ms-perspektive.com you will find the show notes, 11 free tips as a PDF and lots of other information. And now the show begins. Thanks for tuning in again and welcome to episode number 84, Vascular dysfunction and multiple sclerosis, how your vessels could shape your MS journey with Dr. Jonathan Pansieri. Hello, Jonathan. It's such a pleasure to have you on the show. Hello.
Hello. How are you?
Great. I hope you are doing fine as well. And before we actually get into the interview, it would be lovely if you could introduce yourself to the audience so they know who is with me on the podcast today.
Yeah, sure. So I am Dr. Jonathan Pansieri. I'm a neuroscientist working in the medical science division in the University of Oxford. And I'm also a fellow from the UK Multiple Sclerosis Society. So I'm 36 years old. I'm living with my partner, who is also a scientist in the surgical sciences division. So she's focused on prostate cancer. So it's another field. And I'm really a dog person. So sorry for the people who love cats, but I really prefer the dogs and the big ones. So this is probably a problem for me. And as you noticed, I have a very good French accent. So I'm from France. And there's two things we are really good in France, complaining and also making pastries. So the problem is in UK, this is not exactly the same way. So I'm trying to do my own now for, I think, almost 6 years I'm in UK. And this is, believe me, a disaster. I mean, I'm trying my best each time, but I mean, making French pastries is really complicated for me. But yeah, this is who I am.
And I think it's always not so easy to make friends if you are living somewhere else. I was living in Chicago for 1.5 years, and the good thing for me was that my cousin was living there since more than 10 years, so she had quite a big group of friends, and I could just slide in, so that was more easy. But normally it's not so easy to make friends if you're living somewhere else. And yeah, my husband was living in Oxford for 2.5 years and we visited at one point, but I was not allowed to go up the tower at the Magdalen College because only if you are a fellow you are allowed to. So I could only take a look and
there are specific rules.
Yeah, there are specific rules in the high table and very interesting, quite different compared to Germany. Jonathan, how did you got into that field of neuroscientists? What was your personal motivation?
Well, I think I started to study different neurodegenerative disorders since 2014. So I was always, interested in how the brain is working because, I mean, this is a very, very interesting organ and we don't know that much if you compare with the rest of the body. So I started my studies on trying to find, diagnosis strategies for Alzheimer, for example, and I was focused on the aggregation of faulty proteins you can find in the brain. And so I was focused on trying to design these nanoparticles and trying to understand neurodegeneration, how the neurons are dying. But with time, I had, if I can say, and I was not probably the only one, disappointing results trying to find how to mitigate this neurodegeneration. And then I came back to, the basis, and I found that neuroinflammation is probably what happens first. So I decided to shift a little bit from neurodegeneration to neuroinflammation. And had a very good discussion with, my supervisor at the moment. So about multiple sclerosis. And then he said, you want to see neuroinflammation, then come with me. So I said, well, okay. So I came to MS in 2020. And now basically I'm trying to disentangle who is the chicken, who is the egg. and how it is working. So I'm dedicated to investigate, especially the vascular dysfunction, how it can be related to genetic risk factors, how it may impact the progression of the disease. So I hope that all the things we are doing at the moment, and probably what we'll do in the next 20 years, or hopefully less, will help people who are living with MS.
Great. So it's good for you that you were a little bit disappointed in the other field. No, sorry for the other guys, but we have to have good scientists here. So you already mentioned we will be talking about the vascular dysfunction and how it impacts MS. So how much do we currently understand about the vascular dysfunctions that influence the severity and outcome of multiple sclerosis?
Well, that's true that our understanding of how vascular problems influence MS has come a long way. But there is, I think, still a lot to understand about it. What we know is what is the most common at the moment is we know that the disruption of what we call the blood-brain barrier is essential in multiple sclerosis. So if we step a little bit back, the blood-brain barrier is like a hermetic shield. So this is what is very different from the rest of the body. You will have this shield, which keeps your brain safe. You will not get a lot of immune cells infiltrating your brain, and a lot of toxic molecules will not enter into the brain if you're in healthy conditions. If you go in MS, this barrier start to be leaky. And then you will have all these immune cells entering the brain, some toxic molecules coming into it. And then you will have a reaction from your brain that your immune cells will just start to remove all these toxic molecules, starting to mitigate this new inflammatory milieu. So that's what we know at the moment, that you will have this influence of this vascular disruption. There is two main theories at the moment, and we don't know even if they are not, working at the same time. So the first one is the inside-out theory. So you may have some signals from the brain, specifically in MS, which will alter this blood-brain barrier, and then you will have a degradation of this shield, and then things will start to come in. The other one is the outside-in. Some people believe that you will have some events which start in your vessels and coming into your brain that degrade this blood-brain barrier, and then you will have all these toxic infiltrates coming into it, and then you will have the global view. But I think the relevant thing is, back in time, we were thinking that it was just, a reaction, a side effect, something which is just, a snowball effect. But now we are pretty sure that it's something central to the pathology.
Yes, I remember when I'm studying multiple sclerosis management, and in the first module we had Professor Stadelmann-Nessler, and she was explaining that, is it starting from the inside? Is it starting from the outside? And I remember that thing, but there were so many new things because I'm not a doctor. I'm the only one studying this, being not a doctor. But yeah, very interesting. And you mentioning it, that it could be even both. Let's see. I hope it will be found out in the near future. So we will be able to find new solutions to treat MS. So how challenging is it to establish a clear connection between the vascular dysfunction and the way MS presents in an individual?
Well, actually, this is extremely challenging. So we know that there is this effect, but I think there are some parameters very important to take into account. As you know, I mean, MS is clinically unsurpassed in terms of heterogeneity. You will have a lot of different, symptoms. Some people have motor dysfunction, which comes from mild to severe. And even with time, these symptoms will evolve differently. Some people have cognitive dysfunction with memory loss. Some people have even other parameters like pain, and numbness and fatigue. So This is difficult then to even say what is MS. We know that you have a lot of different parameters, but I mean, people living with it, some people have mild problems, some people have very severe symptoms. So that's the first thing, as the clinical presentation is different from one patient to another, linking have a clear connection between the amount of vascular dysfunction and MS is difficult. The second part, which is important, is the genetic background. So we know that there is a clear connection between genetic background and MS. And now we know, for example, that there is more than 200 genetic risk factors identified to be involved in MS. So from one individual to another, then the inflammatory milieu and this vascular dysfunction can be very different. You can add to this what is now well established, the link with Epstein-Barr virus, or even, smoking, sun exposure. All these different factors can impact the vascular dysfunction you can see in individuals. The third part should be that vascular pathology at the moment in MS is not, a 1 or 0 answer. It's just like you have it or you don't. I think what is important is the MS is so a demyelinated disease, but even the demyelination in an individual is different. Some people have very active demyelination. Some of them are what we call inactive demyelination, which means that you will have immune activation or not. So then the blood supply and the vascular dysfunction is very different between these individuals. So the last thing I can say, but now it's progressing very quickly, is the lack of reliable diagnosis tools we had in time. We had limitations. We can see blood-brain barrier disruption with imaging, but sometimes it doesn't correlate directly with the severity of the disease because it's dynamic. So sometimes you may miss what happens. For example, in relapsing remitting MS, you will see that during a relapse, you will have immune activation, but also your vessels will be bigger. You will have a thickness of the vessel wall. But then when they are remitting, then these vessels go back to normal, and then you can miss it. So that's where it's difficult, I would say, to connect directly things with each other. But I prefer to have some hope at the moment, because at the moment we are combining a lot of new technologies. So we know better the genetic background, but we also have all these omics technologies. So all based on the DNA, the RNA, and then how they translate to proteins, so what is called the proteomics. And we have also new imaging tools and AI. So by combining everything together, I think we can be better at, knowing which people can have something more severe or not, and how to link with the vascular dysfunction.
Very interesting. And yeah, the complexity gets more and more the more you dive into the topic. And so you were talking about the severe form. So are there any specific markers of vascular dysfunction that have been consistently linked to the more severe forms of MS?
Well, that's a good question, actually. I think at the moment, there is no consensus. So there is not something universal just to say that, okay, this is the marker of vascular dysfunction. There are tones of them. So we're just trying to disentangle which one can be the most prominent one, the predominant one. One good candidate for this, I would say, and that's something you can see actually in other neurodegenerative disorders, is the fibrinogen. The fibrinogen is a clotting factor. So this is a very important one, even in your body in general, because when you will be wounded, you may have this fibrinogen coming, and then it will clot. It will help you not to bleed. So, but it's not expressed in the brain. So it's something in the rest. And then what we know is we found, and others also, that when your blood-brain barrier is leaky, the fibrinogen will enter the brain and start to accumulate around the vessels. You have a huge expression of fibrinogen. And it's not only clotting, this is pathological clotting. This is not something because you believe that if you have clotting in the rest of your body, obviously you will have some other molecules to clear it. This is not the case in the brain. We found it in a lot of MS individuals, and that's also something you can find in AD. So that's something really linked to something leaky, to see all the vessels not, protecting efficiently your brain. And also with postmortem studies, people found that this is related to the global inflammation and even the death of the neurons. So we believe that the fibrinogen can be something very important in the future, because if we find how it entered the brain, how it affects all the cascade of inflammatory pathways and neurodegenerative pathways, I think we have something here. There is another thing really important, I would say, and we have preliminary data, and that is the metals metabolism. So metals are very important in the brain. So basically, the brain is, as I said, well protected. There are not that much things entering the brain. Probably most of the things are linked to glucose. But you have some metals, and they help, for what we call the translational modification. So some molecules need to have modification to be activated and protect. But the problem is always a balance. So you need metals like iron to help, and you need a balance in the concentration. When you have too much of it, most of the time you will have pathological consequences. So what we have found is that the iron accumulation is exacerbated in MS, and that's something you find in the spinal cord. The spinal cord is very important in the MS pathology. This is where you will find lesions. Most of the axons are demyelinated. That's something you can see by MRI. But we found that the iron is accumulating all along the spinal cord. And what was interesting and always difficult to understand in MS is we know that demyelination is important, but this is not directly linked to the motor dysfunction you will see in patient. Most of the time, it starts with the legs and it will go up to the body. But we have nothing, relating exactly what happens in the lumbar cord and then to the cervical cord. So from the bottom to the top. But the iron accumulation, we have this gradient. We found that we have more iron accumulating pathologically in the lumbar cord. And then less going to the cervical cord and nothing in the brain. So we believe that this can be specific markers showing this vascular dysfunction, and that is reflected in the symptoms of the patients.
Wow. That's really so much new stuff I'm learning in the interview with you today. Very interesting. So let's move a bit on and let's talk about the role of microglia in MS. What role do microglia play in the development and progression of MS, and how do they interact with genetic factors?
Well, the microglia are basically the immune cells of the brain. So they are the macrophages you can find in the rest of the body, but that's the one which are, the resident immune cells, along with other ones called astrocytes. But this is basically a police. So you will have the brain, and then the microglia will move in all the areas. When there is a site of injury or any site of, problems, the microglia will go there and they will start to mitigate inflammation or neurodegenerative processes. So that's what they should do. But then they can, become rogue. And when you have too much infiltrates or too much inflammation or too much neurodegeneration, they will come into the site and they don't care. They will just provoke inflammation. We need to understand that most of the time inflammation is a good thing. That's what happens, in the rest of your body. You are sick, you will have temperature, but then this is because your immune system trying to mitigate, and you will have increased inflammation. The problem is when inflammation is too high, and that's what happens in MS. You will have too much microglia, and this microglia will activate inflammatory factors. They will release cytokines, too much of them, and then it will start to be deleterious, toxic. Well, that's the basic view. The basic view is microglia is bad in MS, and in health, it's good, trying to mitigate inflammation. What we know, and that what the field is shifting at the moment, is that you don't have only bad or good. So microglia can shift in their phenotype for pro-inflammatory and anti-inflammatory, but they can be both. So that's where I think it's important to draw a line. We need to identify what are the pro-inflammatory microglia, what are the anti-inflammatory one, and trying to help one or the other way, depending on the inflammatory milieu of the brain. As an example, so we know that there is a genetic risk factor. For example, this is the HLA-DRB115. This is a genetic risk factor of MS. So it's not only to get MS, it's even during MS, it can, influence the severity of MS. And this genetic risk factor is linked to the microglia activity. What we found is basically people who are not carrying this genetic risk factor, when you relate the microglia activity to the health of the neurons, they are related. More you will have microglia, more the neurons will be protected. So there is a protective role. But people who carrying this genetic risk factor, you lose this relationship. Basically, the microglia is dysfunctional. So what is important here is that the microglia with people with this genetic risk factor is not more inflammatory. It's just the microglia is not protecting. So this is something different because it's not, influencing this huge inflammation. This is just because it's not protecting. So that's where I think we need to consider that all these molecules are participating to the disease, but sometimes it's not because they are harmful. This is just because they are not assuming the role.
So we need to bring in some street workers to explain them that our brain needs to be protected and not that they are overreacting. Yes, it's always complicated. It's not like in the fairy tales. There is the bad one and the good one. Yeah. It's way more complex. So how could targeting microglia potentially lead to new therapeutic approaches for MS based on our growing understanding of genetics?
Well, actually, so as I said, I think there is good hope that we can find pathways, to shift this microglia state, trying, to have some subpopulations of microglia, targeting them, making them more protective, or conversely, for the ones who are releasing too much inflammation, trying to target them, and then, to inhibit this inflammatory response. So it will be beneficial effects at reducing the global inflammation. So I think that improving this research is very important. I would say also that I think I didn't mention it, the microglia, and it links to what I said before, this blood-brain barrier I said before is tightly linked to microglia. If you see a vessel like this, you will have a lot of molecules attached and cells attached to it just to protect. The microglia is interconnected. This is something going to its patrol, but sometimes when you have a leaky vessel, they go there. And they just say, oh, okay, so there is a leakage. I'm trying to mitigate it. And they have, processes like hands, and they go to the vessel and try, to close it. So I think, again, as you said, it's very difficult and tricky sometimes. You have subpopulations, some of them are reacting. They are not, they are dynamic. So it's not, something static. So that's why we need to consider personalized medicine sometimes. It's just like some people will have more or less leaky vessels, and the microglia may come more or less. And we need to be very cautious in our way to think about targeting microglia. It's just like we really need to know specific pathways.
Yes, otherwise we do more harm, I guess.
Exactly. But that's exactly the point. That's why we are always cautious in our investigations, because it's just like, well, we want to help, but if we are not, having not the global picture, but at least something, robust, then we can do more damage.
Yeah.
There is maybe something else in the context of microglia outside of treatments, which is very relevant, is about diagnosis. Microglia activity. So that's something known, that basically in MS individuals, you will have more microglia activity. We don't know if it is good or bad, but there is more microglia activity. So there is something called the translocator protein imaging. So it is the TSPO imaging. So it's a marker of the microglia activity, and people are using it at the moment, even in the clinics, just to assess the disease activity linked to the microglia activity. So you can basically see or having some insight about the severity of MS using this imaging technique. So that's something which needs to be standardized, but other things I have seen recently, even with conferences and colleagues, this is very promising. You can have ideas about dynamics, and they can use it just to say if you may have something more or less severe.
Okay, cool. So let's talk a little bit more about the genetic research. Why, with the increasing knowledge of the genetic basis of MS, how might this influence the development of new treatment strategies? I remember there was an interesting paper on the last ECTRIMS with different reasons, for example, why people with African genetics have MS and why Hispanics have MS. And this was very interesting, but maybe give us your thoughts.
So that's completely true. This last probably 10 years, we made more progress than ever in the genomics. All this, I call it the omics because now everything is omics. So we have genomics, transcriptomics, proteomics. They even say lipidomics. So, but because it's what they call big data. And that's true. We have a number of molecules identified in individuals going from 100 to thousands. So I think it will help. But as we said before, we need to be very cautious. The problem is with this big data, we will find a lot of things. We need to disentangle which one is probably the most important. So in the past, we had the HLA-DRB115, but now we can have hundreds of identified genes which can be relevant. So my point is just it can help, but we need to be very cautious. So that's true. And that's probably underlooked at the moment, that if you go into Caucasian or Africans or even Asians, you will see differences. Actually, MS is so far more prone to happen with people in the west part of the world. That's just something we know, that probably you will be more prone to get MS if you are from the west part. But it is maybe also the fact that we don't have this much data about different ethnic origins. So that's something probably to push forward. And that's exactly actually what we are trying to do at the moment, seeing, going deeper in, this genetic background. At the moment, what I know, so except for the HLA-DRB115, which is well known and still we continue to try to see how it impacts the severity, you have different genetic risk factors of interest. So one is the dysferlin. So the dysferlin, so they call SNPs, it's just a small locus in some genes. This is linked to metals, iron accumulation again. This dysferlin is very interesting because it's about iron storage, how basically you will have more iron and then the iron is not stored as it should be, and then implies different response. So that's something people have found, and even more interestingly for this genetic risk factor, is that some people found a link with MS, some don't. Why? It's because recently someone did a very interesting study by separating the progressive forms of MS and the relapsing remitting one. And he did, again, the investigation of this dysferlin. He found that in relapsing remitting, there is no connection. But if you go into the progressive forms, then it becomes really prevalent. So this goes, again, in the way that we need to consider MS as very heterogeneous. This is something, that's why the personalized medicine is very important. We need really to consider that MS is widespread and different forms can be linked to different genetic risk factors. So, but, well, what I would say, because it's not very positive at the moment, is that I believe that for very severe forms of MS, there is definitely a genetic background that we will be able to identify very quickly in the next years, and it will help a lot of people.
Okay, great. And that makes sense. I mean, it was discussed that probably you need to change the medication at one point. So let's say you're in relapsing mode, you need to concentrate on other forms of inflammation, and then when the distinct inflammation stops and it's going more in the background, you need to concentrate more on the iron problems and some other issues. Yeah, very interesting.
Well, in a perfect world, I mean, for me, we should have a screening of, the genome of everyone. We should have, something standardized when possible. You have someone coming, you just do the screening, then you identify the different genes at risks, and then it will help you to scale the treatment you will give for people living with MS. I think it will help a lot because sometimes you have interactions you don't know. Having this background, which is a basis because you have obviously other comorbidities, but this can help actually, and especially to manage the pain. I think that's something very important to take into account.
Yes. So let's talk a little bit about what is the same and different in MS, dementia, and Alzheimer's. What commonalities exist between multiple sclerosis, dementia, and Alzheimer's disease in terms of their underlying genetic and pathological mechanisms?
Well, so MS and AD are both chronic neurodegenerative disorders. What is important and the common landscape is that they progress with age. So there is really a huge impact of aging in both disease. So there are different symptoms, but there is also overlapping areas, especially more specifically about cognitive dysfunction. So this is something common, unfortunately, in AD with memory loss and loss of synaptic plasticity, which then you will be more reactive. But that's also something you can find up to 70% of MS patients. So these symptoms can be the same sometimes. In terms of pathology, this is quite actually compelling to see that there is a huge overlap. You will find more microglia activation, more neuroaxonal loss. You will find also more vascular dysfunction. Everything is related. You will see same events, sometimes in different brain regions, but sometimes same events. We have seen actually recently that it can affect the same area of the white matter, the same areas of gray matter. So there is an overlap, and actually one can impact the other. So there is really this commonality between them. There is also other commonality about genetic risk factors. So one is well known about AQP4. So this is a water channel. And that's something known in MS to be involved in vascular dysfunction because it's something tightly linked to this blood-brain barrier. In AD, it's even more problematic because there is this vascular dysfunction, but it's also involved in promoting amyloid aggregation, but still they're related. And I would say that the other commonality you can find between them is, again, the HLA-DRB115, because you are the HLA-DRB115 in MS, but you have another one called, so it's just a mutation, a variation of the same locus called HLA-DRB113. So, but basically, they affect the same mechanism, the same processes. So they differ at the end. But this is interesting to see that both of this locus can influence the susceptibility of each disease.
Okay, so let's talk about the differences. How do these diseases differ in their impact on the brain, particularly in the context of neurodegeneration and immune system involvement?
Well, so there is a common ground, but that's true that, and in a sense, luckily they are different, because if there is too many overlap, why it should be two different diseases? I think in terms of mechanisms and manifestation of the disease, AD is the quintessential neurodegenerative disorder. So what happens most of the time is that you will have this accumulation of proteins called amyloids that will aggregate everywhere. So with predilection for hippocampus, that's why you will have the memory loss. But this basis is amyloid aggregation and then influencing directly neurodegeneration. They will accumulate everywhere. And then the neurons and the connection between them, called the axons and even the synapses, will be destroyed. So that's the basis. The basis is neurodegeneration, the death of all the neurons and the axons. And you can't recover from that. In multiple sclerosis, you will have something different because it's more inflammatory. What happens basically is your immune system is exacerbated in terms of pro-inflammation. Then it will attack the axons, and the axons are protected by myelin. So this inflammation attacks the myelin, and then you will have reduction of the transmission of signal between the neurons, so they can't efficiently work. And then with time and age, you will have neurodegeneration. So when one is predominantly inflammatory going to neurodegeneration, in AD, it will be neurodegeneration and side effect will be inflammation.
Interesting, yes. So, and could a breakthrough in the treatment or understanding of one of these diseases potentially offer insights or benefits for treating the others?
That's a very interesting question, because probably it was two or 3 weeks ago. So we submitted a paper about this. So I would say yes. Recently, what we did is we tried to investigate the amyloid deposition in MS, because this is something completely overlooked. We don't know. Well, I mean, there isn't a huge debate, I would say. Some people say that there is no involvement. Some people are saying there is. But what we found was completely the opposite we were looking for. We found that so the amyloid deposits you find most of the time in AD are completely reduced in MS individuals. You have less. So, and even less than non-demented controls. So it's not something, marginal. It's basically that in MS, you have even less amyloid deposition than in anyone. So this is something very interesting for AD research, because if there is any MS-related factor which is able to remove this amyloid aggregates, then it can help to treat Alzheimer. So that's, for us, not at the moment, it's a limited breakthrough, but very interesting in a way to understand these objects.
Okay, yes. I mean, it would be lovely if we, by having MS, could help other people, of course, well, through you scientists. But if somebody, if somebody would find something how to reduce it for the Alzheimer patients.
Well,
but yeah.
I hope not to say to people, if you want to lose AD, I will give you MS.
No. Don't mean that one. But if you find out why we have less,
no, you're right.
And you could, in a way, make that a treatment for the Alzheimer people, that would be lovely. Okay. Yeah, I'm still impressed by all the new things I've learned, especially on the iron and how it accumulates in the spinal cord. But let's come to the quickfire Q&A session. Complete the sentence. For me, multiple sclerosis is?
Well, multiple sclerosis is for me a complex challenge that drives my passion to help people, I would say. It is my probably mission to unravel the different, events leading to this condition.
Yeah. What development would you like to see in the field of multiple sclerosis in the next 5 years?
I would say that I want to shift actually in personalized medicine. We have everything in hands to, improve the treatment and the diagnosis and even, the care. I would say that something which is sometimes overlooked is the pain. We really need to help people and just to have this personalized medicine. If we go directly to my field, which is more, something about understanding the disease, I hope advancement about the interplay between inflammation, vascular dysfunction, neurodegeneration, glial activity. I think this is very important, and I hope that what I said helped, but I really hope that people in my field will understand that they are not, static objects. We really need not just to say 1 or 0, bad, good. We really need to focus on they are different. They are dynamic. We just need to find the way how they, react to something. But I really believe that this is the way we will, find interesting things to help people.
Yes.
And the final thing, so this is a huge debate at the moment. All the conferences I came to, and even the colleagues I'm talking with, the AI is a very powerful tool, but I'm always a little bit afraid that we will use it not in the good way. So what I hope is just to use the tools as they are, just tools, not to replace something else. We just need to cautiously use them. And in the field, I want to use these tools, but in the correct way. So that's why I always saying that we are at the crossroads in the field, but we just need not to make mistakes as we always did in the past.
Fingers crossed. Yeah. Finally, what message of hope or encouragement would you like to share with the listeners?
Well, I think I would say that to everyone living with MS, that you're not alone. We are all working together. Each day, for me, the experiences, the voices of people with MS are very important to scale my research. This can be difficult sometimes for a researcher, who is working in his lab, just to really see, people with MS. That's essential to have this discussion, have discussions with clinicians, have discussions with people living with MS. And this is very important for me to scale. I had discussions with some people with very severe MS, and they told me, yeah, but what are you doing for my pain? And I was trapped because I was just like so focused on, my research that I lose the sight. So what I want to say that there is more hope in the horizon. We have a lot of data now. We have to be clever, but breakthrough are made every day. So we are really trying our best. I would say that brighter days will come. So I would say keep pushing forward together.
Yes. And absolutely. I mean, I was joining the ACTRIMS 3 years ago for the first time online, then last year in person in Milan, and this time, due to my little baby, again online. But this time it was really so much new stuff and so many interesting topics. And it was really like, wow, so much progress in 1 year. And I think it won't stop. So that is really great news. And it's lovely that people like you are coming to my show and give us some insights in a way that we can understand it. So thank you very much for this. And of course, thanks to all the people you are working with. So Jonathan, how and where can interested people follow your research activities?
Well, so That's true that I didn't develop that much my social networks. So sometimes I'm really an old person to this, so it's a disaster. But you can follow me. So I have some professional accounts, or the ResearchGate, LinkedIn account. That's where I can discuss with anyone who wants. If you want to discuss with me, I have a Twitter account and another one for my group that you can, follow, because we give updates about the conferences we go. Also, we have a social or public events we can do sometimes in Oxford. And we also give updates about our research, so publications or even, talks we give. So that's probably where you can find me. And I think that's it.
Fantastic. And of course, I will link them so you listener can find it in the show notes and the blog article. Jonathan, thank you very much. That was really interesting. I really mean that I learned a lot of new things we did not have in our studies, and I was not aware at ACTRIMS. There's so much new information. It's not possible to overlook everything. But thank you very much, and thanks to everyone.
Thank you for your time. Before. Thank you a lot for your time. This is a very good opportunity for me just to, share what we do and what other people are doing in the MS field. So we are progressing. Thank you so much, and thank you everyone for support and everything. So.
Yeah.
Thank you.
So bye to lovely Oxford. Bye.
Yeah. A very nice city. Even if some people want to meet me in Oxford, I will be really pleased. And this is a very nice city to see.
Absolutely. I have to go there again. Was there just once, but yeah.
It will be my pleasure to welcome you.
Fantastic. I will talk to my husband. Bye.
Bye. Thank you.
I hope you enjoyed the interview and learned something new like me. And by the way, next time I will be talking about rehabilitation and the news that were presented at ACTRIMS. So please tune in again and stay as positive and healthy as possible. And see you next time. Bye. Thank you for listening today. I hope you found it helpful. You may also be interested in the previously published episodes and posts, which you can find at ms-perspektive.com/podcast. Perspective with a K. You can also get a free PDF with 11 tips for your positive impact on MS at ms-perspektive.com/newsletter. If you'd like to get in touch, you can reach me at nele@ms-perspektive.com or on social media. See you next time.